other ones are actually anti-grade wiring, or what is parallel wire. So this is a parallel wire. You enter, you got stuck, leave the wire there, and use another microcatheter and another wire and try to poke at the lesion and enter into the true lumen. Otherwise, you can do a seesaw, which means a microcatheter and wire. Both are left in that plane, and use another microcatheter and maybe a seesaw technique by which you can keep exchanging which wire you're going to cross into the true lumen, and that you might be successful. So parallel wiring through the double lumen catheter is also possible. You can use any type of double lumen catheters to do that. And in antegrade dissection reentry or retrograde dissection reentry, knuckle wiring is important, and you need crosswalk, and you can easily do that with the antegrade dissection reentry, which many of the Americans love doing that. So in retrograde, I think, as I said, I'll skip these. Looking at collaterals, several steps, about 10 steps of in retrograde, making sure you can reach the collateral, cross the collateral, confirm the guide wire in the true lumen, and cross the collateral with the microcatheter. Then finally, you're coming to the CTO, where you have to cross CTO, wire externalization, and then treating the CTO, and remove externalized guide wire safely, and then actually take an angle to make sure there's no damage at the collaterals. So you need to change strategies, which I think is obviously, if you're failing in one, don't be stuck on that one. So in this study of 4,000 patients, antegrade dissection reentry was done, antegrade wire escalation was done in 80% of the patients, retrograde was done in 14%, and ADR or antegrade dissection reentry was done in 7% of the patients. But if you look at actually the total successful in people with antegrade wire escalation and another strategy, the success rate go up to 87%. And the same thing with the retrograde as well. Don't be stuck on one, keep exchanging, so the success rate is in the 80 to 90%. So the idea is to somehow open up the CTO, but not be stuck on that. I only do antegrade, I only do retrograde is foolish. We need to keep changing the strategy. But at the time that you're not successful, think that you're now in the investment phase. And this is what actually looking at another large population, whereas actually the second procedures were done, repeat CTO PCIs, and still antegrade wire escalation was the most dominant in the second procedures as well, 41% of the patients. Retrograde was used in 27%, the other one in ADR is 17%. But what is the MACE rate in second procedures? It's not high, it is 3.3%. So procedural success was achieved in 83% of the patients with the antegrade, with the second PCI procedures. So here is a patient where SUO3 failed and Sion Black was successful. So don't get stuck on that, okay, this is SUO3 case and if one wire is not successful, go to the next wire. So, and post-stenting here you can see what is the next step. You see the dissection. And then a Mongo catheter was inserted, and basically T3 flow was restored ultimately in these patients. So finally, the number 10 is stopping. Don't do procedures beyond 3 hours. And if the air karma is more than 5 grade, contrast use is much higher than 3 times the EGFR. Complication has occurred, and options, you have exhausted and you're tired, the team is tired, probably it is better to stop. The most important for us is also, of all these 14 steps, monitoring. For hemodynamic support, you need to monitor. How do you monitor? There's lots of things that you monitor, right? You monitor radiation dose, you monitor ECG, blood pressure, oxygen saturation, where the equipment position, maybe just changing 5 degrees this way or that way will help the patient get the less radiation in that particular area. So operators are responsible for monitoring everything in the room, and the ACT to make sure there's no thrombus and access site complications, and whether the field is sterile and contrast volume. So for you to be successful, you have to continuously monitor, otherwise you might result in complications, which I'm sure we'll learn more about that. With that, I'll stop here, and I'll be happy to take any questions out at the end of everybody's talk. Thank you.
Thank you. Shiva, great friend and mentor of interventional cardiologists of this country, to the stage, and he will be speaking on advances in anti-critical PCI, new and improved ways to solve more problems. Shiva, please welcome Shiva.
Okay. I think we will not have that much time, so I go through, try to summarize what we have more, or what are the improvements we have done in advanced antegrade CTO. So as you can see, CTO have so many characteristics that everyone can impact on your outcome. And again, as have been shown before, we have 4 key elements in every total occlusion. That means the proximal cap of occlusion, the length, whether it is calcified or tortuous, the distal cap, and collaterals. And of course, all these points might have some problem or had many problems in the past, and we are trying to resolve that, introducing every time some technique, new technique, devices, and so on. Now, approach selection, it is antegrade or retrograde, mainly can be on non-ambiguous proximal cap and good distal landing zone, as well as lesion length less than 20 millimeters, then I think the first option should be antegrade approach. Retrograde approach, when we have ambiguous proximal cap, good interventional collaterals, or very diseased distal landing zone, or bifurcation at distal zone. But again, even in these cases, if you have relatively short total occlusion, I will try antegrade again, antegrade. Now, antegrade approach, we can distinguish 2 approaches. This is the antegrade wire escalation, and the second is antegrade dissection and brain tree. And though both can be done with short as well as long lesion, both should be done when you are using wires, whether it is retrograde or antegrade, that means escalation of wire. Now, initial strategy is selected to taper cap or plant cap or ambiguous cap, as we have said, and we have seen so many algorithms showing how to proceed. But I think, again, algorithm cannot be every time followed, because algorithm means mathematics, I have said before. And I think sometimes you should use something more, or add something to algorithm, or take something from that algorithm down. So I think it depends on the operator, it depends on your experience, and it depends on your knowledge about techniques and possibility to open the vessel. It's not proceeding anymore. Okay. Now, what we have improved, of course, the dedicated CTO wires have extraordinary improvement, and now really we have a variety of guide wires can be used in different situations, but again, knowledge of what you are using is very important because selection of guide wire is depending on your experience, on the characteristic of patient you have in front. And of course, every guide wire has his own characteristics, and operator should know, and we do not have now time to go through all these characteristics. Not going ahead. Second improvement, very important improvement, is microcasters, which can really make your life easy during a procedure, particularly when you are go for wire escalation, wire exchange, and so on. And the advantage, what we had used in the past was over-the-wire balloon, but we have big advantage of microcatheter over the wire balloon, because they have smaller profile, larger internal diameter, make a tip allows for exact positioning the marker on the tip, as well as the resistance of kinking as compared to over the wire balloon is also another big advantage. Another big improvement is by some devices introduced, like crossbars, that been mentioned before. This is particularly important and can help in antegrade dissection and reentry, whether you are doing that from antegrade or retrograde. But retrograde, I think it is very difficult to cross with crossbars in some collateral. So it is not that easy to use. It's much more easy to use in antegrade. And we have dual looming catheter, which helps so much in doing the dual parallel technique, or the protecting side branch in bifurcation occlusion, or exchanging wire during your procedure, leaving the one wire in where is it. And microcatheter, again, normally is used by horsework wire to arrive till the occlusion. Then over that you position your microcatheter, and then you can start your procedure knowing that you have the access, good support, and zero risk in exchanging wire not to reach or to dissect before. Other important improvement is that we have the CT angio, coronary CT angio, which can help in many situations to define the vessel and to give you absolutely detailed information about how to plan your procedure according to the specific anatomy of that patient. And intravascular imaging, of course, is very important. Particularly when you are doing dissection and reentry, then you can see exactly where you are, and you can be sure that you are having good reentry by IBUS. This is not needed always, because if you are have good visualization by angio, then you can see a lot also by angio, but sometimes it could be really of help. And again, we have defined how to move the wire, how to proceed with the wire. That means control drilling technique, penetration technique, sliding technique. So all these are movements can be mixed one together, but of course require good manipulation of the guide wire, as well as in some situation you should need a certain type of movement rather than another, as well as bend on the tip of the wire should be made accordingly. Again, what I have said before, when you have short lesion and ambiguous proximal cap, you can go with both antegrade or retrograde, but again, in my experience, I go always by antegrade first, and then if needed, if I will not succeed or for some reason, I can go for retrograde. And long lesion as well, until if it is not that much long,